Thank you very much for having me here tonight. We're going to talk about a lot of the things that were brought up by the patients who were on the panel. And again, I want to thank the patients who shared their stories with us. And a lot of the things that they mentioned we'll be talking a little bit about tonight. And so this is sort of the outline. It looks like a lot of stuff, but a couple of these things we'll go through pretty quickly. One of the things I have in there is the staging. A lot of the patients mentioned what stage they were, and I get asked that all the time, so I thought I would just spend a few minutes on that, and then I'm going to give you a few updates on what's happening in stage 4 melanoma, and also what happens once you finish your immunotherapy, and the side effects of some of these new treatments. As Annette was mentioning, it's very different from what we're used to when we talk about chemotherapy. And so we'll go through some of that. And then lastly, and the more exciting part of it, is we're going to talk about the new treatments in adjuvant therapy, which we've been waiting for a very long time. So just in terms of a little bit of an introduction, as you may know, melanoma is a form of skin cancer. It's the most aggressive of the skin cancers, and I know someone asked a question about basal cells and squamous cell carcinomas. They tend to be not aggressive like melanoma is, and often they're cured just by surgery alone or other methods. But often patients who have melanoma, because of the sun damage that they've had, will often have other skin cancers like squamous cells and basal cell carcinomas. But melanoma, even though it makes up less than 5% of the different types of skin cancers, it is the most deadly out of all the different types of skin cancers. It also affects many young patients in the prime of their life, and it is now the most common cause of cancer in women aged 20 to 29, and this is one of the new statistics from the US. And they think a lot of this is attributed to UV exposure, especially from tanning beds. We know that early stage melanomas are generally curable, and mostly with just surgery. And now we have a lot of things going on in terms of different therapies and clinical trials looking at new agents. And this has really changed the course of treatment and how we treat patients in melanoma. And that's what we're going to be talking about for most of the presentation today. This just shows you how things have changed pretty dramatically since the 1950s up to now. There's been over a 600% increase in melanoma. And also increase in mortality, not as much as the incidence. And we know that melanoma is one of the major cancers that keeps increasing every year by about 2 to 3% every year compared to most of the other cancers. Oops, wrong way. And this is just to show you, even though it's not one of the most common cancers that's out there, like breast cancer or colon cancer or even lung cancer, it is the 4th most common cancer that's diagnosed in younger people, so between the ages of 15 and 49. And as I mentioned previously, it is the leading cause of cancer death in young women in the US. And if you live here in Canada and you're male, your lifetime probability of developing melanoma is about 1 in 57, or about 1.7%. If you're female, it's about 1 in 75, about 1.4%. And if you compare this to some of the other countries, like Australia, where the incidence is quite high, the incidence there is more like 1 in 20 or 1 in 25. And in the US, it's about 1 in 50. So we're not far off from a lot of the European countries and the United States. However, as I mentioned previously, because generally if caught early, most melanomas can be cured, and the 5-year relative survival overall is about 90%. So many people do quite well if it's caught early enough. So some other information in terms of how we approach melanoma. So if many of you have been to our clinics or clinics at Princess Margaret or some of the other centers, you end up seeing a lot of different doctors all at once, the surgeons, the medical oncologists, the dermatologists, and so on. And that's because really melanoma is treated in a multidisciplinary fashion where you need input from all these different specialists to be able to get the best care. We know, as I mentioned, if the main treatment is surgery, and Dr. Wright's going to be talking about that after my talk. You know, and someone brought up the issue about cure, and are you ever cured with metastatic disease? And to be honest, we don't know, and we'll talk about that a little bit more as we go through some of the information. Generally, we've always thought that metastatic disease is not curable, and that's for pretty well all the cancers. But, you know, things are changing where that's concerned. We've known for a long time that chemotherapy it wasn't great in terms of response rates or improving how long patients had to live. We used to think that radiation also didn't have great results, but that's also changed because the technology and how radiation is delivered has changed drastically over the last 10 years, and now they can give much better focused, high precision radiation, and the results are much better where that's concerned. But now I think we're in a different era, and up until 2011, the only drug we really had to treat metastatic melanoma was a chemotherapy called DTIC or dacarbazine. But since then, there's been a lot of breakthroughs in terms of some of the molecular testing in melanoma and classifications of melanoma, and really immunotherapy. And the two people who discovered the two targets for the immunotherapies we're going to talk about have just received the Nobel Prize, just like in the last couple weeks. So it's pretty amazing stuff that's happened over the last 6 or 7 years, and not just for melanoma. They're using immunotherapy now to treat almost every other cancer as well with some good results. So this is part of the molecular pathways that I just mentioned. So there's a few things that are important in terms of the survival and how melanoma cells divide and survive. And if you've been in some of our clinics or some of the other clinics talking to your doctors, we talk to you about we're going to send your melanoma off for testing for some markers. And some of these markers include BRAF, NRAS, and c-KIT. And the reason we do that is because these proteins are involved in these very specific pathways that control how the melanomas grow and divide. So by blocking these different aspects of the pathway, then hopefully we block the cell division and stop the melanomas from growing and try and kill off the melanomas. And so what they've done is that over the past many years, there's been many drugs that have been developed for each of these different targets. And we're going to be talking about some of these drugs today, especially the BRAF and the MEK drugs, because those have really changed how we treat melanoma. And in terms of these BRAF markers, we know that about 40% of all melanomas contain this BRAF marker on their melanoma cells. And it really depends on the type of melanoma that you have, what your chances are of having this BRAF mutation as part of your melanoma. And so if you have the type of melanoma that came about because of sun damage, the chances of you having a BRAF mutation is much higher, about 50%. If you have a different type of melanoma where it's in mucosal surfaces like the inside of your mouth, your nose, sometimes the gut, then the chances of that being BRAF mutated is much, much lower. And even if you have melanoma that arises in your feet or surface of your hands, then again, the chances of the BRAF mutation are much lower. And if you have uveal melanoma, which we're not going to spend very much time talking about today, then they have very different mutations. And they're working on therapies specifically for those mutations in uveal melanoma as well. So we have a couple of strategies for how to target the melanoma with different therapies. So there's the strategy of immunotherapy, where the immunotherapy basically targets the host or targets the person. And by doing that, it does that by stimulating the immune system, and then the immune system cells go out and they target the tumor. Or we have a different strategy of targeted therapy where the therapies actually target the tumor themselves. And that's the BRAF and MEK pathway that we just talked about, and the drugs that have been developed specifically for that pathway. And those drugs work by targeting the tumor itself. There is a little bit of immune boosting that goes on even with some of those drugs, but not to the extent of the immunotherapy drugs that we're using. So in terms of the targeted therapies and these BRAF drugs that we keep talking about, we refer to them as BRAF inhibitors. And There's 4 different ones. There's dabrafenib, which is taflunar, trametinib and is Mekinist, vemurafenib, zelboraf, and cobimetinib, which is Cotellic. And these drugs are used in combination. So we either use the dabrafenib and trametinib together, or we use the vemurafenib and cobimetinib together. Okay, and we'll talk about that in a little more detail. And then for immunotherapy, which is the one that targets the person, we have several drugs, and some of them have already been mentioned because some of you have been on them as part of your treatments. So the first one is the ipilimumab, or Yervoy, and that was one of the first drugs that was developed back in 2011. And then pembrolizumab, or Keytruda, nivolumab, which is also Opdivo, and now we are also using them in combination. So we have combinations of nivolumab and ipilimumab. And I practice lots to be able to say all those names. Okay, and then one of the things I wanted to talk about a little bit is because it came up a few times, and also because I get this question asked quite a bit in terms of what stage am I? And I get asked that all the time. And it really depends on several features of the melanoma. So the first feature we always talk about is how deep the melanoma goes into your skin, or how deep the melanoma is. And that's referred to as a T stage. And so depending on the depth, then most patients are either stage 1, stage 2, and so on. The lymph nodes are the other category. And this is usually figured out by the sentinel lymph node biopsy, or if you have palpable lymph nodes, or lymph nodes that have gotten swollen and they're proven to be melanoma. If you have lymph nodes involved of any kind, whether it's through the biopsy, the sentinel lymph node biopsy, or because a lymph node has come back with melanoma, then that's considered stage 3. Okay? And then once the melanoma has spread beyond those lymph nodes into other parts of the body, including liver, lungs, wherever, brain, that's considered stage 4. Okay? And so just keep those in mind as we talk about some of the treatments and where we're using some of these therapies. So we're going to start off with a little bit of an update from the metastatic melanoma part. So as I mentioned before, prior to 2005, there wasn't much happening. We basically had the dacarbazine, or the DTIC. We had another treatment called high-dose interleukin-2, which is pretty well now not really used very much. There may be the odd center in the United States that still gives it, but really now that we have better therapies, no one really uses it. And then this was replaced by what we like to call the era of hope. And this is where all the other drugs were developed. So between 2005 and now, all these drugs were developed in terms of the immunotherapy drugs as well as some of the targeted drugs. And now, since 2011, we have 7 drugs that have been approved to treat melanoma in the metastatic setting, and all of these drugs showed an improvement in survival for patients with metastatic melanoma. So this was a huge improvement in what we had previously, and you know, we no longer tell patients that they only have 6 months to live. So I know there was a lot of discussion about that before, but we certainly don't do that anymore because that's not the case anymore with any of these treatments. So the 2 BRAF drugs that we mentioned before were the vemurafenib and the dabrafenib. And basically the advantage of these drugs is that they're all oral drugs, so they're pills that you can take at home. They work very well and they work fast, but the way we use them is in combination with each other, just like I mentioned to you before, the dabrafenib and trametinib. And this is because they found through different studies that they worked better together than each of them by themselves. And so we now have long-term results from many of the clinical trials that were done using these drugs, and we know that at 5 years, there's about a third of the patients that are still alive, but if you had low amount of disease when you started out, there's more than 50% of patients that are still alive at 5 years, which was unheard of, 7 years ago, before we had these drugs. And they're fairly well tolerated overall. The most common side effect that we see from these drugs are a fever, and I'm sure some of you who've been on these drugs might have experienced this already. Skin rash sometimes, sometimes aches and pains, but overall most patients tolerate them fairly well. There are some less common side effects, and one of these is inflammation of the eye. This happens in about 1% of patients and can be treated easily with steroids, so it's not very common. The more common things are the skin rash, which, to be honest, now that we use these drugs in combination, we tend not to see the severe skin rashes that we used to see when we used the single agent drugs. And also the calluses. This was a big problem when we used the drugs by themselves. Now that we use them in combination, thankfully it's gotten rid of most of the side effects, except for we still do see the eye inflammation once in a while, but it's very rare that happens. The other mutation that I showed you on some of the other slides, which happens in about 15 to 20% of patients with melanoma, is called NRAS. And generally, from the data that we have so far, we know that patients whose melanoma has this mutation tend to not do as well as some of the other patients. However, now that we have immunotherapy works just as well in someone who has an NRAS mutation and somebody who doesn't. It doesn't really make that big of a difference. We do have another drug that we can use specifically for patients that have NRAS mutations. That drug, however, never received approval because the benefit wasn't big enough for the governments to fund the drug, but we are able to get it sometimes on compassionate basis through the drug companies. So patients with an NRAS mutation would have another option for treatment, as well as the usual immunotherapy that we would do. c-Kit is one of the other targets as well, and we also have drugs for patients with c-Kit mutations. These tend to be the patients that have mucosal type melanomas or the melanomas on the hands and the feet. Those tend to be the ones that have the c-Kit mutations, because it's not very common to have one of these markers on your melanoma unless you have a mucosal or hands and feet. And we do have a drug called imatinib or Gleevec, which we can also get on a compassionate basis for patients with the c-Kit mutation. But again, you also have access to immunotherapy. And so a little bit about immunotherapy. As we talked about, the immunotherapies target the immune system, and they specifically target the T cells. And these T cells function to go after and destroy the melanoma cells. Just like they would if you had an infection or had something else going on in your body. The T cells are the parts of the immune system that would go after the infection. And the benefit of the immunotherapy is that it works whether you're BRAF positive or negative, whether you're NRAS positive or negative, whether you're c-Kit positive or negative. It doesn't really matter. It works for everybody. The drugs that we have, the ipilimumab, the pembrolizumab, the nivolumab, these are all approved and funded here in Canada for us to use in stage 4 melanoma, and it's pretty well our standard therapy for anyone who develops stage 4 melanoma. However, the immunotherapy does have some unique properties, and we'll talk about a few of these. One is pseudoprogression, and you may have heard your doctors talk about that sometimes the tumors may get bigger before they start to shrink again. And the reason for that is when your immune system gets boosted and all your cells, all the T cells are trying to go after things, sometimes they get into the tumors and they swell up the tumor. And the tumor is swelling because of the T cells and your immune cells, and not necessarily because the tumor is growing. And that's what we call the pseudoprogression. And here, this is just an example of it. And you could see here on this person's CT scan, you have a mass there. And then 3 months later, it's gotten much bigger. But then when they repeat the scan 4 weeks later, it's starting to shrink. And then continues to shrink as time goes on. And this happened because the immune cells infiltrated the tumor and made it swell up, and not because the tumor was actually growing. And same thing down here. This is a person's lungs. This is a nodule in the lung, and then it got bigger, and then pretty well almost disappeared 4 weeks later. And again, same reason, because the T cells get in and infiltrate it and make it swell up, and then eventually they calm down and things get smaller again. So in terms of what really changed how we treat metastatic melanoma, there was lots of trials that happened with various different drugs. This was the trial that looked at pembrolizumab compared to ipilimumab in melanoma, and basically showed that there was an advantage of using pembrolizumab over ipilimumab. And more recently, we have data that now goes out to almost 4 years. And we know that at almost 4 years later, we still have over 40% of patients that are benefiting from pembrolizumab, which, like I said, even with the other drugs, this was unheard of with any type of chemotherapy. And even for many of the other cancers, this is unheard of for any type of treatment. And you know, this is the part where we're kind of stuck and not sure what to say in terms of cure, because we're seeing that these things are leveling off as time goes on, but we don't have enough information yet, because these drugs are fairly new, to know that 6 and 7 and 8 years from now that this curve is going to look exactly the same. The hope is that this just keeps leveling off, and this is where we stay. And for this, we're going to need more time to go by and more information before we can say that, yes, you're good once you reach 4 years. And this just shows you just the difference between all the patients, and if you had not received any treatment at 4 years, that your benefit was a little bit better compared to someone who had received previous treatment for their melanoma. But really, overall, it didn't seem to make any difference whether you'd had treatment first with one of the other therapies, such as the dabrafenib or trametinib, or something else, or you were part of a clinical trial, or whether you got the pembrolizumab up front. Either way, the patients did just as well. And then for nivolumab, we also have data out to 4 years, and it's basically the same. This was a much smaller study, but even with their bigger studies, the data is pretty much the same. There's really not a big difference between nivolumab and pembrolizumab. They're basically the same drugs, but made by 2 different companies. So in terms of how well they work, or in terms of the side effects, they're pretty much the same. It's just a preference of whether you want to come every 2 weeks or whether you want to come every 3 weeks, basically. But now the nivolumab has just been approved for every 4 weeks. So you can actually not have to come as often for your treatment. So the other question I get asked quite a bit is, what happens once I complete my therapy? So for pembrolizumab, we treat for a total of 2 years of treatment. And so what happens once you stop your therapy after 2 years? And now that they have a little bit more information, they looked at their clinical trial where the one I showed you earlier, where they compared the pembrolizumab to the ipilimumab, and they looked at the patients who had finished their 2 years of treatment and what happened to these patients. So they had 103 patients that completed their 2 years of treatment, and they looked at what happened to them, and they saw that about 63% had a partial response, about 27% had a complete response, and then there were about 9 or 10% that had stable disease. I think looking at this, and just looking at this number and the number of people that actually their disease goes away completely, that's what the CR means, is that your disease is completely gone. To me, this is amazing, to have almost a third of the patients where their disease goes away completely. So when they looked at this, they saw that if you'd had a CR, and they looked at these patients 2 years, so 20 months after they've completed their therapy, after they completed their 2 years of therapy, and they saw overall that there were about 86% of the patients were still doing really well after 20 months of completing their therapy. And what they saw was that if you'd had a complete response, if you're one of the patients whose disease went away completely, 96% of those patients at 20 months were still doing great. If you'd had a partial response, it was about 90%. The ones that didn't do as well were the patients that had the stable disease. And I think this is really good information for us to have, because this hopefully will guide us in terms of treatments and what to do with those patients that have the stable disease. Because if we can see it early on that your disease is going to stay like that and it's not going to change, then maybe those are the patients that we need to give different treatment to and treat differently for a period of time so that we can get them closer to what these patients are doing, up in the 90% range. So there are some clinical trials that are going to be looking at that kind of strategy in terms of what do we do now to try and make that better. But the message I wanted to get across here is that this is a new concept, because people who are on chemotherapy for their metastatic disease, generally you're on forever. And now that we have immunotherapy, you stop the treatment and we just watch you. And sometimes it's a bit scary when you finish your treatment and we're just watching you with tests. But we have good information that says you do really well if you've done well up until that 2-year mark. So this is really good for us to know. And I mentioned earlier, we now also have combination therapy. So we knew that nivolumab works really well by itself. It's very similar to the pembrolizumab data I just showed you. And we knew that ipilimumab worked well. And so they've combined the two drugs together. And what they see is that it works a little bit better than the nivolumab by itself, probably by about 5% or so. So if you look here at 2 years, there were more people alive with the nivolumab and ipilimumab than they were with the nivolumab, by about a 5% difference, okay? But the side effects are much worse. And so here, for the combination arm, about 55% of patients ended up with a severe immune-related side effect. And we're going to talk about what these immune-related side effects are. Whereas in the nivolumab arm, it was about 16%. Okay, so, and usually when we have a discussion about whether we do combination versus single agent, this is the information that we talk about. So in terms of the immune-related events, as some of the gentlemen here and people in the audience were talking about before, generally if you're on immunotherapy, you do feel like Superman. You know, a lot of my patients tell me, are you sure you're really giving me drug? Because I feel great and I'm not having any side effects. And that's great, because that's how most people feel. Most people may get a little bit of fatigue after they get the infusion, or a little bit of flu-like symptoms for a couple of days, sometimes a rash or itchy skin. And beyond that, you know, they feel pretty good, unless you end up with one of these immune-related side effects. Okay, and basically what these are is these are side effects that are caused by inflammation and by the T cells that are in your system. Because what happens is, normally, when you get a cold or you're sick with something and you boost your immune system and your T cells are going around trying to fix things, there's mechanisms in your body and in your immune system that shut down those T cells so that they don't cause inflammation and they don't cause problems. What these drugs do, what these immunotherapy drugs do, is that they actually block those mechanisms. So they take the brakes off so that the cells just keep going and going and going and going, and they don't have a way to shut themselves off necessarily. And so because of that, sometimes they can cause inflammation in any other part of your body and cause problems. The chances of that happening with the pembrolizumab and the nivolumab is quite low. It's under 15%. But with the combination, it's much higher, and that's what we'll talk a little bit more about. The majority of the common ones are the ones that affect your gut, skin, as well as endocrine and liver. The most common one out of all of these is the thyroid. So there's about a 20% chance, if you're on any of these immunotherapy drugs, that you'll end up with some kind of thyroid dysfunction that will require you being on a thyroid medication for the rest of your life. Because once the thyroid is inflamed, then you'll need replacement hormone for that for the rest of your life. The chances of all those other things happening are actually much lower than that. So in terms of when do these things happen? They can pretty well happen anytime while you're on treatment. Most tend to occur after you've had a few doses of the treatment, and they can occur up until 2 years after you've stopped your treatment. because it really depends on how activated your immune system is, and whether or not you're going to end up with any of these side effects. Thankfully, most of them are treatable with high doses of steroids. That's what we do, and aren't lasting forever, except for things like the thyroid. Okay? So as I mentioned, it can pretty well affect any part of your body in terms of the inflammatory type immune side effects. So if it affects your lungs, we call that pneumonitis, and really the chances of that happening are only about 3%. The most common one, as I talked about, is the thyroid, which is about 10% of the side effects, and then the rest are actually quite rare. You can see here, they're all under 1%, and for the nivolumab and the pembrolizumab. But there's a difference if we're using the combination, and that's where the more common things are the gut, such as the colitis and the diarrhea, liver inflammation or hepatitis, and some of the skin rashes and so on. And as I mentioned, really what we do for any of these is we manage them with big doses of steroids. And often you'll need to be on steroids for about 4 to 6 weeks, and we slowly get you off the steroids, and most people are fine after that. And often we can retreat you and continue on the treatment as long as everything went well during that time. The important thing is that we catch these things early and that you're aware of them, so if anything is happening, you tell your doctor as soon as possible, because the earlier we catch it, the easier it is to treat, and the shorter time you'll need to be on the steroids, and then we can get you back on your treatment. We also know that if we have you on these steroids for weeks, that it doesn't affect how you do with the treatment. And there's lots of studies that have shown that being on the steroids doesn't make any difference in terms of how much you're going to benefit from the drug. The drugs still work whether you're on the steroids or not. Okay? So just to summarize this part, and then we'll move on to the adjuvant treatment. As we talked about, some of the targeted therapies like the dabrafenib and trametinib, they're great drugs because they're pills. You can take them at home. You don't have to come in for treatment. They work great. Often they shrink things down very quickly and can cause a lot of relief for people, and especially if you're having pain and so on. And we know that there's long-term benefit from being on these drugs with 30 to 50% of patients still doing really well at 5 years. We also know that immunotherapy can show some durable responses, and I showed you the information for 4 years, and over 40% of patients still doing well, and hopefully that will continue on. And then we know that the combination works a little bit better, but we have to think about the toxicity and make a decision of whether or not it's worth it for the toxicity that it causes. And then really in the future, what's happening is they're looking at more combinations of different therapies, but ones that are less toxic than the combination of the nivolumab and ipilimumab. So different doses, different combinations of different drugs. But the best thing is that now that we've had all these drugs in the stage 4 metastatic patients, now these have moved over to the adjuvant setting. And we'll talk a little bit about that and what's new in this era. So in the adjuvant therapy, there's been lots of different trials that have been done over the last couple years. And to be honest, most of this is fairly new. And most of this we've just had information in the last 6 months in terms of these therapies in the adjuvant setting. And so really what adjuvant therapy is the additional treatment that we would give you once you've completed all your surgery and we know that you're disease-free. And as far as we can tell, everything is removed, but there's still a risk potentially of the melanoma coming back down the road because you may have some microscopic disease that's still there that we can't see with the naked eye or even with scans of any kind. And so because of that, if you're high risk, then we would offer you adjuvant therapy. Prior to 6 months ago, over the last 20 years, there were all kinds of treatments that were studied and looked at in this setting. None of them really had any benefit, and you could see interferon is on that list, and we'll talk a little bit about that. But now we're seeing really good benefits with immunotherapy and the same targeted therapies and immunotherapies that we just saw in stage 4. So when do we talk about adjuvant therapy and when do we use it? So we look at different features of the melanoma that are important in guiding us in terms of what your risk is going to be of the melanoma coming back down the road. And the things we look at how deep the melanoma goes into the skin, whether or not there's any ulceration. If there's ulceration as part of the pathology or part of the melanoma, those melanomas tend to be a little more aggressive. Whether or not the lymph nodes are involved, and the mitotic rate. And this is what really guides us. Currently, we use adjuvant therapy for stage 3. So anyone who's got lymph node involvement, currently you would be a candidate for adjuvant therapy. The higher risk stage 2 melanomas, which are the deeper melanomas, so the ones that are greater than 4 millimeters, they could have ulceration. There will be a study that's opening soon. I think we're opening here, I think late November, early December, treating those patients with pembrolizumab and to see whether there's a benefit in the stage 2 patients. But currently these drugs are for the stage 3. And the reason for this is because we know that with the stage 3 patients, the more lymph nodes you have, the higher your chances are that something's going to come back and the lower your survival with your melanoma. So those are the patients that got targeted first in terms of all the clinical trials for treatment with adjuvant therapy. So here in Canada currently, we have high-dose interferon that's funded. You've heard about that from some of the patients who received it. There has been lots of studies looking at interferon. We tend not to use it very much. I mean, we used it when we had to because we really didn't have much else. But the benefit is not very high. And you could see here, I mean, it's only a 3% benefit and lots of side effects. We now have the dabrafenib and trametinib approved for patients that have a BRAF mutation, and this is for stage 3 melanoma. And this just happened like last week that we have it approved. It's not funded yet, but now it's going to go through all the funding mechanisms. And we have a study opening in a couple of weeks for patients that have stage 3 so that we can get the drugs to the patients, and hopefully there'll also be some kind of compassionate program that will allow us to give the drugs until they're funded by the ministry. We now also have results from all the immunotherapy drugs, ipilimumab, pembrolizumab, and nivolumab, but these are fairly new and they're going through for approval at Health Canada, but they're not yet approved. So hopefully in the next few months, we'll also have approval for the pembrolizumab and the nivolumab. We also do use radiation sometimes. Radiation is used for a control locally. So if someone has a lot of lymph nodes that were involved or large lymph nodes that were involved or something that we call extranodal extension, which means that the melanoma cells were able to get out of the lymph node and into the tissue around the lymph node, those patients would be the ones that we would approach about radiation therapy. And basically what the radiation does, it treats only locally where it's given, and it reduces the risk of the melanoma coming back in that area. Because if you have a lot of lymph nodes or bulky lymph nodes, the chances are higher that it's going to come back locally even after surgery. Okay. So in terms of the adjuvant trials, as you can see here, there's a big list of them. We're not going to talk about all of them. We're going to talk about the ones that are in yellow. I'll give you a little more information on those. This first one was vemurafenib versus placebo. And vemurafenib is the single agent drug, which is a BRAF inhibitor. And basically this study was a negative study. The vemurafenib wasn't any better than the placebo by itself. And it's not really a big surprise because we know that the combination of drugs like the dabrafenib and trametinib and the vemurafenib and cobimetinib used together work much better. So single agent drug by itself, we really don't use that in the adjuvant setting. We like to give the combination. There was also a trial looking at ipilimumab, and we'll talk a little bit about that. The trial that looked at dabrafenib and trametinib compared to placebo. And then there's 2 trials that we're still waiting for results. And these were trials that compared interferon to ipilimumab. And this one was also an interferon trial, but I'm not sure how relevant it still is nowadays. And then the nivolumab compared to ipilimumab, and then the pembrolizumab trials. And we'll show you some information about those. So the ipilimumab was one of the first immunotherapies that we used for stage 4 melanoma. We tend not to use it as much anymore because we know that pembrolizumab is better than ipilimumab, so we tend to use that. But it was also studied in the stage 3 melanomas, and it was never approved here in Canada, but it was approved in the United States and some parts of Europe. And the reason for that was because the benefit wasn't great enough, and because of the toxicity associated with it. And when they looked at the data, and they looked at, even though it wasn't compared to interferon, they looked at the interferon data, the benefit didn't look that different. So it was never approved in Canada, and now really it's fallen out of favor in the United States as well. But the problem with it also was the side effects from it. And there were about 36% of patients, probably almost 50% of patients that got some really bad toxicity on this drug. And they had several patients die on these trials because of toxicity from the ipilimumab. And for that reason, it was never approved here in Canada. And we don't really use it. But you may have heard about it because you see it being used in the US, but probably not as much anymore. The other trial that we recently got results for was the dabrafenib and trametinib study. And these were the 2 drugs that were just recently approved by Health Canada. And they basically looked at the 2 drug combination together compared to placebo for patients that had stage 3 melanoma. And what they saw at the 3-year mark is that they had there was much less patients that had relapsed in the dabrafenib and trametinib arm compared to the placebo. So that there were those that were free from relapse, there was about 60% in the dabrafenib and trametinib compared to 40% in the placebo arm, which was very significant. And when they looked at the survival, there was also about an 11% improvement in survival at 3 years for the patients that received the combination of dabrafenib and trametinib. Now, these drugs will only work if you have a BRAF mutation. They don't work if you're BRAF negative or BRAF wild type. So these drugs would only be useful in patients who have a BRAF mutation. Okay. And in terms of the side effects, the good thing was that the side effects aren't any different than what we see in the stage 4 patients. So the most common thing was still the fever, some of the fatigue, and the skin rashes that we see. And then when they looked at nivolumab, which is one of the immunotherapy drugs compared to ipilimumab, they also saw that there was a benefit at 2 years of about 13% for those patients that received nivolumab versus placebo. And same with the pembrolizumab study, where they compared it to placebo, was about 70% versus 53% at 18 months for those patients who had received pembrolizumab for their adjuvant treatment. Now, the benefit of the immunotherapies is that, like I said before, just like it was in stage 4, it doesn't matter whether you're BRAF mutated or wild type or negative or any mutation for that matter. It works for all the patients. And then in terms of the toxicities, again, the benefit was, again, that we didn't see anything different than what we saw in the stage 4, because there was a lot of concern when they started these trials in the adjuvant setting whether the toxicity was going to be worse, because the thought is that your earlier stage, your immune system is probably more intact and better off than you are when you're in the metastatic setting, and maybe these drugs were going to cause worse immune-related side effects, but they didn't, and they aren't, so that they turned out to be pretty well the same. So just to summarize, so we now have 4 drugs that have shown a benefit in the adjuvant setting. The dabrafenib and trametinib is already approved, and we're waiting for the nivolumab and pembrolizumab. The ipilimumab will not get approved here in Canada as a single agent by itself because we know that these 2 drugs are better. These have all shown a benefit in the relapse-free survival, and 2 of them have shown a benefit in overall survival. As I mentioned before, it didn't really make any difference in terms of whether you were BRAF negative or positive in terms of who benefited from it. And the good thing was that we didn't see anything worse than what we saw in the stage 4 patients. The only disappointing things from all these different trials is that most of these trials excluded the mucosal patients. So we don't know whether the benefit is the same if you happen to have a mucosal melanoma in your mouth or your nose, whether you're going to get the same benefit as what these trials have shown, because those patients were excluded. And then we're waiting still for some other results from a few of the other trials that are still ongoing. So just to conclude, as I showed you previously, we're in an era of hope. We have lots of new treatments that have come to be in the last 7 or 8 years. As I showed you before, the targeted therapies work really well in the metastatic setting. The immunotherapy has shown really good responses. But finally, we have better adjuvant therapy. And now we don't have to use interferon anymore, which is for us a great thing because none of us like it, and you guys probably more than us. So we're very happy that we don't have to use interferon anymore, and we finally have some good therapies, because the hope is that by treating the stage 3 patients, there's going to be less metastatic disease, and we are going to be able to cure some patients in that setting. And I thank you for that. Thank you for your attention, and I'm happy to take any questions. There's been trials looking at those 2 drugs in combination, looking at the effect on the brain metastases. And we know that they do work in the brain, but they just don't work as well as they do in the rest of the body. But they are able to get across the blood-brain barrier and treat the brain metastases, but we know that they tend not to work as well as they do in the rest of the body. And it's exactly like you said, because the brain has a protective mechanism called a blood-brain barrier, which tries to keep things out so that your brain doesn't get toxic. And so because of that, it's very difficult for many medications to get across, but those drugs do get across the brain to treat. I have quite a few patients that have been on for 4, 5, 6 years on those drugs, and they're fine. So as long as you're tolerating them fine and you're not having any toxicity from them, you can be on for a really long time. What we don't know is whether we can actually stop them and not have the melanoma come back. And so, some people, sometimes we do that because we have to, and some patients do really well if we stop them, and other patients' stuff starts coming back and we have to put them back on. So it just really depends. We have discussions about this all the time, and the sustainability of how much these drugs cost. And to be honest, I don't think there's an easy answer. And all the province, Canada kind of has a pan-Canadian approval process, but then the funding is provincial. So all the provinces make their decisions in terms of how they're going to fund these drugs. And all the provinces are going to be struggling, and not only because of melanoma, but because immunotherapy works in many other cancers, especially some of the more common cancers like lung cancer, for instance. And so there's a lot of discussion at the provincial bodies in terms of how are we going to be able to sustain these drugs. Part of it is negotiations with the drug companies who make these drugs in terms of the cost negotiations. So there's committees that do that negotiate the price of the drugs. And other strategies about maybe getting rid of some of the medications that we know don't work, that we were using from a long time ago, and shift some of the funding over. So there's a lot of different things that are going on, and there's not an easy answer for sure.
Yes. You
We have information, and this was part of the staging slides I had initially, and I had to cut them back because the presentation was way too long. But we have information that tells us that if you are a stage 3A, which means you have the one lymph node involved, and if you have less than 1 millimeter of disease in that lymph node, we know that your chances of being alive and well in 10 years is almost 90%. So for those patients, we do say you're better off watching and waiting because your risk isn't that high of something happening to you down the road. Whereas for the patients that have more than 1 millimeter of disease, then their chances are higher of something happening. So that's sort of how we divide up the patients. So if you have a small amount of disease, it's reasonable to wait because your chances are so good that nothing is going to happen. Thank you very much.